the first surgery, second surgery, impression procedure, lab procedure, fixation, and even the complication has been discussed, that is the peri-implantitis. So, audience, we have to see that why there is complication, why there is peri-implantitis. We are seeing that near 50 to 75% failure of implant is happening due to the improper designing of occlusal scheme in the single implant and in the full arch rehabilitation. That means in the over denture and in the fixed partial denture, improper designing of the occlusal scheme. Let me say something before installation of my seminar, that is the occlusion. Occlusion is the static teeth contact between maxilla and mandible, and which is the basic to all aspects of the dentistry. Even in the OMS, conservation, orthodontic, the postodontic, the children, occlusion needed. And this occlusion is of several types of the occlusion in the natural and in the artificial occlusion. In the natural occlusion, usually mainly happening two types of occlusion. That is the canine guided occlusions, roof function occlusions. I will show here inshallah. And in the artificial occlusion, there are some occlusal schemes. That is the balanced occlusion, lingualized occlusion, monoplane occlusion, roof function occlusion, centric occlusion. Centric occlusion is ICP, intercuspal, and acentric occlusion other than the centric occlusion. That is during the protrusion, lateral excursion. This is the acentric occlusion. Articulation. Articulation is the dynamic teeth contact. What is happening with me? I am just speaking and the teeth are coming in contact. And during the deglutition, the teeth are coming in contact. And during the mastication, these are the dynamic teeth contact, and we call that this is the articulation. My audience, masticatory force are acting in between the maxilla and okay, let me start my occlusion. By the appearance of the osseointegrated implant, the treatment option has been changed in the postodontic. The rehabilitation of the partially and the complete edentulous jaw completely has been changed, and it is done by the implant. And we know that in the implant there is no periodontal ligament. So, as there is no periodontal ligament, the occlusal force are more occurring, excessive occlusal loads are occurring over the implant system. The buccal surface will be reduced. Not to happen, the tongue bite. What is happening here? What is the advantage of reduction? The palatally and the buccally. We can see here, the upper, the palatal cusp is the functional cusp. The tip of the cusp, which is functional, is acting at the lower center point with the central fossa of the lower implant. And the force is going along the long axis. There is no offset force, no long axial force, no bony resorption, my dear. And he is saying that reduce your cuspal inclination in this way, in the right one, see? If we reduce the cuspal inclination, one study is saying that if we reduce only 10 degree cuspal inclination, it will reduce 30% occlusion growth. And one study is saying that in the earlier one, if you reduce 30 to 40% of the crown diameter, there will be, sorry, here it is mentioned in the Fujimoto, 60 to 70% occlusal fold will be reduced, my dear. So reduction of the crown will reduce 60 to 70% occlusal fold, can you believe? And reduction of the cuspal inclination 10 degree will reduce the 30% occlusal load. Why we don't do this? We will not rely over the lab. We all individual will be lab. We will do the trial in our clinic after knowing these things, my dear. And there will be success, inshallah. This is very much important. We can see that the anterior tooth mesially distally movement more. See, the central incisor is 108, lateral is 97, and the canine is 64, but you see the molar is 56. Mesial distal movement of the incisors. So, if one implant is placed in the anterior teeth, what will happen? The patient cannot aware of hyperocclusion. Why? There is no sensory biofeedback mechanism in the implant. There should be premature contact. So it should be checked by us, by the SIM stocks, which is less than 12 micron, I will say just. This is that. The occlusal contact, the timing contact is very much important. Whenever the maxilla and mandible is going to do bite, within the light force, there will be no occlusal contact with the implant. And there will be gap, minimum 30 micron. Why? I will mention, don't worry. With the implant, in the light contact. But whenever the patient is doing the heavy contact, ICP, maximum interdigitation, there should be contact of implant after sinking of the natural teeth, which is having 25 to 100 micron axial coronoapical movement. So after movement of the natural teeth, the implant is coming with the natural teeth in contact. That means whenever there is light contact, in the primary contact, there will be no contact with the implant. Whenever there is heavy contact, the implant will come in contact. And it will be done by us. No need to rely on the lab, my dear. Do occlusal adjustment in your clinic. Believe it or not. And we can see here, the force is not with the central fossa, with the lingual cusp, with the marginal ridge. What will happen? There will be cantilever force, there will be offset force, long axial force, which will act at the crystal bone of the implant, and there will be bone loss. So, occlusion is the key to have success in your implant, my dear. Believe it or not. You have done everything. First surgery, second surgery, impression procedure, lab procedure, done, and it is fixed. No occlusion, result will be zero. You see, you judge yourself. And so what to do? What to do and how? The red point is the central fossa. This is the primary contact. And the green one is the secondary contact. The question may arise. Speaker, is it easy? Very easy. Not to have a contact with the lingual and the buccal. No, not so easy, but it is easy, my dear. How? We can allow the primary contact only on the central fossa, and it should be checked by the shim stock articulating paper. And we will not allow any teeth contact with the marginal ridge and with any tip of the cusp, with the opposite one, except the functional tip of the cusp. which will be against the central fossa of the opposite teeth. And question arising, the teeth having the pinpoint cusp. So do grind and increase the diameter of the tip of the functional cusp. Even grind the central fossa of the crown suprastructure, increase the surface and have nicely contact with the central fossa with the blended cusp of the functional cusp of the teeth. Here we can see the primary contact, there is no contact. But in the secondary, we can see here, and it is the shim stock, which is less than only 12 micron. So by using this, with the light contact, it will come easily out. But whenever there is heavy contact, it will not come out because the adjacent teeth are sinking, apically movement happening, and the implant is coming in contact with the opposite teeth. Whenever there is secondary movement, very much important, my dear, because in implant there is no PDL, no primary movement. But in the natural teeth, the secondary movement is there by the deformation of the bone. Tension zone and the compression zone, there is movement, orthodontic is playing role. But in the implant, no PDL, only osseous movement is happening, and it is depending upon the elasticity of the supporting bone. That's why one is saying that the occlusal force, which is compressive, is stronger in the compression, 30% lesser in the tension surface area, and 65% weaker in the shearing zone. Very much important. Okay, so here, if the position is not correct, if the position of the implant is not correct, see what will happen? There will be cantilever force, and there will be costal bone resolve. Here also, we can see the diameter is more, implant is there. So here there is creation of the cantilever force and bone resorption is occurring. And this is very much important. The contact point, we know that in the posterior teeth, the buccal 1/3 is giving the contact point, and the contact point between the first molar and the second molar with the middle 1/3 of the occlusal surface. So increase the embrasure at the contact point to reduce the occlusal force. Three part of the finger is there. One is the apical 1/3. So increase with the middle one, half of the middle one. Then it will decrease the occlusal force, which will be helpful to maintain the long stability of the implant system. And now, and last, I will take only 5 minutes to finish this lecture, inshallah. So now I am going to do say something about the occlusal scheme for the full arch rehabilitation, which may be done by the fixed partial denture, which may be done by the implant supported overdenture. And here there are the occlusion needed is, first one is the bilateral balanced occlusion. And there are some parameters, some ideas in which cases we will give which type of the occlusion. Bilateral balance is which one? Which one? Bilateral simultaneous teeth contact both in the centric occlusion and acentric occlusion. So in all sort of movement there will be teeth contact. See, in the first one it is the centric occlusion, all teeth are in contact. This is the protrusive, the mandible is coming forward, but all teeth are in contact. In the right one, the working side, teeth are in contact. In the left one, the functional cusp to functional cusp is in contact. So, in the working side, on which side the mandible is moving, cusp to cusp, buccal to buccal, lingual to lingual. and in the non-balancing or non-working side, the functional cusp upper palatal with the lower buccal will come in contact. So this is the way to do the alignment in the implant. And indication say fixed implant prosthesis versus the conventional CD or RPD. If this cases, we will give this sort of occlusal scheme. This is the lingualized in the left one, and this is the monoplane. In the monoplane, both teeth, upper and lower, are non-anatomical. Flat occlusal surface, no cuspal inclination. And we know that 0 to 20 is the semi-anatomical, and 20 to 33 is the anatomical. So in the monoplane, we will use the non-anatomical teeth, both in the upper and lower, but in the lingualized occlusion, see, in the lower we will use the non-anatomical teeth, and in the upper we will use the anatomical teeth, but the criteria is upper functional cusp will come in contact with the central fossa of the implant. Its another name is unilateral occlusion. That means the teeth will come in the working side. Mandible is moving on the right side, the teeth, maxillary and mandibular teeth will come in contact in the right side, but in the other side, it will not come in contact. It will be disoccluded. This is the roof function occlusion. Question arising, my dear. A patient came to you with compromised canine. It is periodontally compromised or missing canine. But indication is to give the canine guided. We will not give the canine guided occlusion. We will give the functional occlusion as there is no canine. Very much important. This is. And this is the last. I take 1 to 2 minutes. Canine guided. I have mentioned that during the protrusion only incisors will come in contact, and there will be gap. This gap is called, the wedge-shaped gap is called the Christensen's phenomena, and it is mentioned. And in the right side, only canine gap there. In the working side, there is gap. So indication is what? Fixed implant procedures versus the natural dentition. Anyone, upper or lower, might have been fixed implant versus fixed implant prosthesis, fixed implant versus implant supported. This is 1 minute it will be taken. Upper complete denture, lower complete denture. Balanced occlusion we will give lingualized or monoplane. Lower all on 2 implant. All on 2 implant. And upper is the CD. We will give these 3, anyone, bilateral, lingualized or monoplane. If upper all on 4, lower all on 2 of a denture, we will give any one of these 3, the bilateral, lingualized or monoplane. But you see, the lower of a denture, yes, I am having 5 minutes more, thank you. So, the lower is of a denture and upper is CD, see? So, we can give the bilateral balanced and lingualized occlusion. See, upper is of a denture, lower is of a denture, but we can give those 3, but the difference will be that there will be no contact over the teeth which is not over the implant. That means the free end area, there is teeth. This teeth will not come in contact. Otherwise, there will be cantilever, there will be rocking movement, and the bone around the implant will be resolved, and in this case will be failed. And if there is natural teeth in one side, an implant supported denture on the other side, then we can give bilateral and lingualized. And let me say, it is that if our denture upper, lower natural with the over denture, we can give these 2, but there is no teeth contact over the missing area. And last one, if there is fixed, detachable upper over denture, we can give all thing we have mentioned, but last of all, let me say is that in the conclusion, our goal of the today seminar should be to decrease the occlusal load. I'm having 1 to 2 minutes just to say something to you, please. To decrease the occlusal force by maintaining what I have mentioned, the 6th point. By designing the occlusal scheme, reduce the occlusal force over the implant. Don't allow any cantilever force, any non-axial force, any offset force over the implant. It will be success, my dear. Any poorly designed occlusal scheme of the single implant or the full arch rehabilitation will result the failure of the implant. Thank you very much.
You have mentioned the upper fixed prosthesis, that is whatever it is over the implant or natural teeth. In lower, there is overtreatment. What type of occlusion you should consider?
Very important question, my dear. Very important question, you know, because you are the artist to give the occlusion. And you have to know how to do the alignment of the tooth. If we follow in the lower jaw, during the alignment of teeth, two components, that is the curve of Spee and curve of Wilson. If we do alignment of the teeth by following the curve of Spee, that means it will give us the concave in the lower, see, in this way. And if we do alignment of the posterior teeth by following the curve of Wilson, it will give lower concave, upper convex, it will just fit. So there will be no gap like the canine guidance, like the groove function. There will be bilateral simultaneous teeth contact, both in centric and ascentric occlusion. I think, hope you have the answer.
Why not canine guided occlusion?
A very good question, my dear. Here there is fixed implant in the upper and in the lower. If we give the canine guidance, you know that what is the canine guidance? Whenever the patient came in the centric occlusion, we ask the patient, move your mandible in any one side. The lower canine is moving against the palatal surface of the upper canine, gliding, giving some force, and coming tip to tip at the canine, and there is gap in the posterior segment, known as the Christensen's phenomenon. If it happens, the other side will come down. You know that in the artificial occlusion, if you want to move any one teeth, whole denture will move in a unit because the teeth are anchored within the acrylic resin, not within the socket of the natural teeth. I think, hope you have done.
Thank you very much. Nice presentation.
Thank you. Any question to any other speaker? Okay, please.
To Dr. Faroukque Shihab, sir. Sir, aesthetic is of paramount importance for doing the implant or any dental restoration or any kind of work for dentistry. So when you are doing the
Crown diameter less.
yeah, crown diameter less, and not only the posterior teeth or in the anterior buccal or anterior segment, how do you maintain the aesthetics of the implant?
A very good question, my dear. I like it. You know. First, come to the posterior segment. I have mentioned reduce the diameter in the upper jaw by the palatal surface, from the palatal surface. In the palatal surface, nobody can see, and the cheek will not shrink. There will be cheek support is intact by the buccal cusp of the upper. And in the lower, I have said that reduce the buccal surface of the lower buccal cusp, not the lingual surface of the lower cusp. But we have reduced the buccal surface of the posterior teeth, not the anterior teeth. So, whenever there is a smile, you see, I am doing the smile, there is buccal corridor, there is gap in between the teeth and angle of the mouth. There is one dark gap is there. We call this region is the buccal corridor. So buccal corridor is giving you aesthetic, my dear, not the buccal surface of the posterior teeth. Our goal is not to happen that tongue bite. If we reduce lingual surface, there might have been tongue bite, because there will be no object to prevent the tongue to come inside the upper and lower occlusal surface. Hope you have to answer. And in the anterior.
Thank you. Thank you.
I'm going to give
Yeah, I think.
Okay, thank you.
Dr. Faroukque Shihab, thank you very much. Actually, I know in this session the presenters presented such a way that if I allow the time, I think we can continue this session up to midnight. I think there are a lot of questions, so I cannot give the time because we know we have a limitation. So I am giving the mic to my friend, Professor Dr. Mahmood Rahman. He is the teacher of Dr. Faroukque Shihab. He would like to say some comment about it.
It's very nice. His presentation was outstanding. Nicely elaborate about occlusion. I think the audience will benefits a lot. But thing is that we should execute it in our clinical works. If you can do it truly in our clinical works, then definitely the patient will get the good service, as well as our community will be praised by the patient. So I do expect it from all of the audience. From now onward, we will continue the prosthetic driven implant, as well as we must take care about the occlusion of the patient. Only one thing I want to include, the last questions regarding buccal reduction.
Two other youngsters, Dr. Onik and Dr. Meherin. Is there any question? So, what should I say, Dr. Meherin? I think all of us, we know or not, she is our proud. She is the daughter of our brother, Professor Dr. Zakir Hossain, the eminent orthodontist and ex-principal of Dhaka Dental College. Actually, to understand the extension and to make a good treatment plan. So she mentioned very rightly that before going to do any implant, we must emphasize the planning and consider various points. And I think today in all the lectures, everybody is mentioned about the importance of prosthodontics, prosthesis. So from these lectures, I think we must learn today that before inserting any implant, we must think about the final result, that is the final prosthesis. So thank you, Dr. Meherin, for your excellent presentation.
Our Faroukque Shihab sir, our chairperson sir, ending the press.